Greetings everyone, this is Timothy, the Digital Apothecary, and I'm going to start with one chapter I'm very fascinated by. So my background is I was actually doing cardiology before I moved to home health care as a clinical safer as an academic, and I was doing heart failure management in the outpatient setting. So cardiology has been something I've been following for a long time, still very much an area of expertise of mine that I love and follow, but you know, this chapter though is very interesting. So just give you an idea, like think about cardiology that you get taught as a module in school. Think about how many weeks you spend on that topic, going over, let's say, atherosclerotic disease, CAD, hypertension, different arrhythmias, heart failure, anticoagulation goes with like AFib and such. How thick is that book chapters, and like hyperlipidemia. Well, in this case, what we have here is basically only about 30 pages. Yeah, so if you go back to 1945 and you look at the pharmacology and therapeutic section, it is 30 pages long. We've come quite a long way. If you start looking here in terms of medications that are used, I mean, what are we dealing with? We got cardiac stimulants, digitalis, quinine, quinidine, drugs acting mainly on blood vessels as vasoconstrictor drugs. We got epinephrine, vasodilators. We got nitrates and caffeine. Yeah, there you go. That's where we're at. So I love the fact that, I love this little image here they have with a heart. I mean, it's not like, it's quite fascinating just looking in terms of like anatomy back then and seeing what they have. Some people might fall and be like, oh, how much do they really know back then? The reality is they were pretty much on top of things still even then, but I think just a better knowledge of conduction pathways have come a lot farther. Now, because you still have like terms like sinus nodes and everything else, contractility, tone, such are there. But what's really interesting is heart diseases. So, okay, let's stop right here. So what heart diseases do you imagine that is going to be listed on the next page? It's not much, because I'm going to flip this over and yeah, what do we got? We got aortic flutter, paroxysmal tachycardia, auricular fibrillation. So again, this is basically aortic atrial. So atrial flutter, atrial fibrillation back then, regurgitation, heart block, angina pectoris, cardiac decompensation, which is just what they call congestive heart failure. And even that looks like it's a newer trend that's coming into play. And then, yeah, that's it. So there's no hypertension on here. There's nothing like that. These are basically what they were really considering in terms of pharmacological interventions that were possible then. So if you were talking about, let's go with basically cardiac stimulants, which for arrhythmias, I'm going to start with one is digitalis. So, or digoxin. Think about today how we dose people. We pretty much have medications we got right off the shelf. We give it to them, right? Well, back then, what you would do is this is just amazing. Reading this for me is I'm gonna read this off. The dosage of the digitalis preparations is quite variable. It is customary in treating a patient to saturate or digitalize him by giving him relatively large doses of digitalis over a period of a few days until mild toxic symptoms are produced. So basically, you give them a loading dose, and once they become symptomatic in terms of having the adverse effects of digoxin, then it's like, oh, that's it, stop taking it then. So I would hope that they stop with the GI and they don't go too much farther with that. So, but this other term, digitalize him, I love this. I call myself the digital apothecary, and this term digitalize and the digital age is there, but yet back then it's basically overloading with digitalis. So basically, once you get to the point within about 24 hours that they are digitalized, then you stop taking it. And when you stop taking it, then you basically, assumption is that they're then going to excrete them out of it within 24 hours, and then you resume them on a maintenance dose. And that is approximately, from what I understand, about half of how much they were loaded on. And that's what you would then do. And then look at how they're dosing this stuff. They're showing all the droppers about how you would do to give it to them. And I also like how they talked about taste. Tincture of digitalis has an unpleasant taste. This can be disguised with syrup of licorice or syrup of I don't even know what erodictium. But is best administered in a glass of iced lemonade or iced syrup of citric acid. That sounds delicious. I am going to give you this glass of iced lemonade full of digitalis that I put a few drops in, chug it, and once you become symptomatic with side effects, then you're going to stop taking it, and then I'm going to give you another dose within 12 to 24 hours, and that'll be your maintenance dose. For us that even like today we talk about Digoxin, about all the different toxicities are affiliated with it, it being such a cheap drug that we use for a long time, which is true. Dosing has still been, something that's very hard to maintain and such for patients just because of side effects, and renal function to take into consideration. But even back then, they're just basically getting the drops of stuff to see. This book is also meant for nursing, as I found out when I was reading through it earlier, and they'll talk about toxic effects. So toxic effects. The nurse must exercise particular care in watching for early symptoms of overdosage with digitalis. These symptoms, which indicate the patient is fully digitalized, are nausea and vomiting, a pulse rate below 60 per minute. And so basically, I guess you were just taking the pulse, and they were just watching, asking a patient, are you feeling nauseous or are you experiencing vomiting? And once then, I guess that was that dose they were giving. So they do talk about congestive heart failure and the use of this drug, and then, which, we talk about today. If you were talking about, let's suppose, AHA, ACC guidelines, I mean, digoxin is still used for heart failure, but it's been replaced, especially with our now knowledge of the RAS system. So if we talk about the renin, angiotensin, aldosterone system, that's not even something that's present in this book. That's not even mentioned. That's not even something that's understood, because ACE inhibitors, aldosterone antagonists and such, the whole idea of the renin system here at play for heart failure isn't even a part of the conversation. We are still so far away from even dealing anything with that, which is really cool, because it just shows you, like, for a disease that nowadays, when we talk about cardiovascular death, is like such a huge component in terms of deaths in the United States. And we have so many medications for it and that are used. In this time period, there really isn't anything. So other ones that I've never even seen before, Strophanthus is glycoside, and this is something that stood out to me. I didn't even know this was something that existed. And as I've read through this book, what's really fascinating is just the number of stuff that has gone away. They don't even exist anymore, or I never even heard of them. There's the whole idea of strychnine and camphor. Both of these drugs have been used extensively as cardiac, circulatory, and respiratory stimulants. Both are convulsive and overdoses. There is no conclusive evidence that either of them is valued for the above-mentioned purposes. Barium. Soluble barium salts are extremely poisonous. Barium chloride, orally well diluted, is used sometimes to stimulate the ventricular heart muscle in cases of attacks of syncope and Adam-Stokes disease, which are produced by temporary stoppage of ventricular heartbeat. Yeah, we don't use any of this stuff. Quinine. So quinine is actually present here, and quinidine. So this is still the early phases where we're actually getting into, if we talk about some of the antiarrhythmics. We then get into the Von Williams classification coming up later, but here this is basically all they have on those. So that's all we got there. So if we're talking about then blood vessels, vasoconstrictors, we got epinephrine, which is being administered hypodermically or IV, and then ephedrine. And then we also have pituitary. Like, what the heck is pituitary? So what they were doing back then is pitressin is one of the two active principles derived from the posterior pituitary, has a powerful vasopressor effect. Since posterior pituitary injection contains both active principles, it possesses a vasopressor effect. The blood pressure rise is prolonged, resembling that produced by ephedrine. So basically, yeah, we're basically giving pituitary messed up injections. Again, it's so, like, I look at this and it's just so odd to me. But yeah, this is something that was being done back then. And the vasodilator drugs, well, all you got is basically nitrates, so nitroglycerin, which we don't often think about being used for blood pressure treatment, but they're doing that here as a vasodilator. And then caffeine is being used. So caffeine is being used to help as a vasodilator. And what's interesting here is they talk about the action here. So in the caffeine derivative groups. So theophylline and theobromine preparations produce dilation of most smooth muscle tubes. This effect is seen in greatest degree in the coronary arteries. The blood vessels in the general circulation area are dilated. Any tendency towards a decreased blood pressure from this cause is usually more than offset by direct stimulation of the heart muscle, so the net result is usually a slight rise of blood pressure, about 10 millimeters. Despite decreased peripheral resistance and hence a more rapid circulation of blood, this is an important factor in the production of diuresis with these drugs. So the reason why they talk about using them, though, is the fact that they can cause some vasodilating effect on the heart directly. So dilate the heart vessels at the cost of increasing blood pressure peripherally. Theophylline these days is mostly known for treatment for basically COPD on the vasodilation effect there. But yeah, so that's basically cardio. Now imagine if you were a student back then. Here's some exercises. What is the main actions of digitalis? How is the patient digitalized? What is the average dose after the patient is digitalized? What are the symptoms of overdosage? When would the use of nitrates be indicated? What are the most important preparations used? Yeah, that's it. So I'm going to pause here and I'm going to jump quick because probably you're wondering right now, well, what about edema associated, let's say, with heart failure? Like, how would you get rid of fluids? That's actually really interesting, but it's not in this section. So I'm going to jump to it. Okay, so I'm back. So diuretics are actually placed under hydrogen ion, water, and salt balance chapter. So this is way ahead. Now we're from page 300 to 582. And there's a bunch of diuretics that are in here, but they're discussed in section. This is really interesting to me. So they have cardiac edema they're talking about. And what they'll add here is the idea of using caffeine or xanthine group of diuretics. So basically they understood that caffeine could help basically cause diuresis. So you got that there. And what they would also recommend is caffeine obtained from coffee and tea, theobromine obtained from cocoa, and theophylline prepared synthetically. But perhaps one that gets me really, really paused, because I've never seen this. I've heard it talked about. I've actually talked to physicians that were practicing back in the 1940s. And the one thing they always mention is the time that they had used mercurial salts as diuretics. So yeah, mercury. And what you have to understand is that mercury is actually a really good diuretic. So here, if you look at uses, the chief use of mercurial diuretics is in the treatment of cardiac edema. They are also used in the treatment of ascites due to liver injury or obstruction of the portal circulation. Although sometimes used in nephrotic edema, they are relatively dangerous for this purpose because of the possibility that they may still further injure or already damage the kidneys. I mean, yes, mercury is nephrotoxic. It causes a lot of damage. So, back then, basically, if you had edema due to heart failure, what did you do? I've heard of things about using enemas in the past, using capsaicin enemas, for instance, to basically induce large amounts of diarrhea, so that they would lose fluid because it would pull it out. But in terms of excreting fluid to the kidneys, basically mercurial salts were like the things they were going to. And if you look in terms of effects, approximately approximately 85% of administered mercury is excreted in urine within 24 hours. The diuretic effect, therefore, usually starts within 2 to 3 hours of injection, is most copious in early stages, and has ceased after 12 to 24 hours. So it's best to get it in the morning, just like we talk about getting like loop diuretics these days in the morning. But yeah, that's it. So we're giving freaking Mercury to help out, basically get rid of cardiac edema. That's amazing. Then you also have cathartics, as I mentioned earlier. Basically, they help draw fluid into the GI tract and then basically excreted. There's some danger from their use in nephrotic edema, since saline cathartics are mainly absorbed from the gastrointestinal tract. So talk about magnesium sulfate. And so the ability to excrete these salts decrease, and that can cause further damage as well. So I'm going to stop there in terms of talking about just how we used diuretics back then, because nowadays when we think about diuretics, we think about thiazide type diuretics, we think about loop diuretics. There's no actually in here really a huge amount of information about how the kidneys even work, which is quite interesting to me. So again, we don't have these classes. They don't get invented for another about decade and come onto the market in the 60s. And so, you know, it's quite fascinating, because nowadays I think any pharmacist, pharmacy student, nurse, anyone in the healthcare field is affiliated with a water pill. Patients know it as the term is water pill. But the idea that back then we had to give mercurial salts to basically help induce diuresis, just for me is quite fascinating. So I think it gives a good example of how far we've come in less than a century of how much we've developed in terms of healthcare. I mean, it's 2019 and we've gone so far. I mean, we haven't really made huge advances with diuretic use, and like this is not even talking about like dialysis. I mean, that's a far way out. So it's amazing. We've done so much, and I think looking at this book just really gives kind of like a concept for me, like just how big we've advanced. I'm going to get to the next section in another video coming up, and it's going to basically be on how did we address infectious diseases, because if you find this interesting, yeah, wait till I tell you about how we used to cure syphilis. It involves malaria. Yeah. All right. Well, this is Digital Apothecary. Take care and have a good day.